So I'm Martin Knapp. I'm Professor of Health and Social Care Policy at the London School of Economics, and I'm part of the NIHR, National Institute for Health and Care Policy Research Unit in Healthy Aging. And what you're going to hear today is part of a series of monthly webinars hosted by that Policy Research Unit. It was formerly the Older People and Frailty Policy Research Unit, and the work that we're going to be hearing today was carried out under that former PRU, Policy Research Unit. So we're delighted to see you here today. So let me explain what we're doing. We've got two presentations. The first one will be from Magdalena Valbaum, who presents an overview of the study, which I haven't told you what it is, have I? It's Preferences and Willingness to Pay for New Models of Social Care for Older People with High Care Needs in England. So Magdalena will present the first part of this webinar today, describing the two phases of the project, and then Michaela Tonelli will present results from the second part, which included what is called a discrete choice experiment, and she will explain what that is and what findings we've got. Now, what we'll do at the end of each of those short presentations, we'll have a Q&A, and what you can do is you'll see at the top of your screen, you'll see a whole series of icons. The one in the middle of my screen says chat, and next to it is Q&A. And if you want to type your questions into the Q&A, what I'm going to do is monitor, and together with colleagues, monitor what's there, and then I will try to bunch some questions if there's similar topics together, and then I will ask the presenter the question and they will respond. So we're going to do it that way because otherwise it's very difficult to manage the time for the webinar. So we'll do that after each of the two presentations. And then throughout the webinar, we'll also post links to any related research and relevant reports in the chat. So you're invited to use the chat as well if you want to, but if you can, use the Q&A function for the questions. Now, some people, if your firewalls are particularly unhelpful, you might not be able to see the Q&A, so you can put your questions into the chat part. We'll try and monitor both of those. Now, to say this is being recorded, so after the webinar's finished, we'll post this onto the website so you can relive it and show it to all your friends and family for their interest. And I just want to say quickly a thank you to Jane and Linda and Nuswa who've helped to organise the series and particularly today's webinar. Okay, so I think that's all I need to say by way of introduction, unless Jane tells me. I'm looking at Jane's face and she's not frowning too deeply, so I think I'm okay. All right, I'm going to hand over to Magdalena, who's going to give us our first presentation. So over to you.
Thank you, Martin. So I'm great.
That's great, we can see it. Thank you.
Yep, perfect. Good afternoon, everyone. So I'm presenting the first part, as Martin said, of this project on the preferences and willingness to pay for new models of social care for older people with high care needs in England. And I'm not going to repeat what Martin said, but this is just funded through our Policy Research Unit. So the aims of the project were to understand the preferences of older people in England for different aspects of social care and how do they trade off different features of care. And as Martin mentioned, so this the work had two phases. So first, phase one was a qualitative work, and then the second phase was a quantitative work that used some of the findings of the phase one. So I'm going to present both the phase one and part of the phase two specifically on the survey, and then Michaela will present the results of the discrete choice experiment. So this is the team that formed part of this whole project. So Martin Knapp, Raphael Wittenberg, myself, Michaela, Alice Koch, Jane McDermott, and other colleagues from our research unit. Also, part of the research team were the people from Kantar that ran the survey. So Rebecca Steer, that was the lead of that team. And we're also very grateful for the people from the Caribbean and African Health Network and the Greater Manchester Older People's Network Health and Social Care Working Group, because they supported this work throughout the whole project. So both in phase one, forming part of the focus groups, but also an important involvement in the phase two of the project. So helping us understand the findings that we had in the phase one and then shaping what we had to include for the phase two. So a brief description of what we did, or summary of our methods. So in the qualitative work, we first started with a review of the evidence of what is out there related to the preferences of older people in relation to the different components of care. So what do people want and what do people prefer for their care? After this, the review of the evidence, we came up with certain key aspects or components of care, as we named them, and we had different focus groups with people to discuss this components of care. We looked at, or we discussed it with people from the general population, but also with people with specific needs and some other subgroups to include a diverse group of people. And then the findings of the work, of the qualitative work, then fed into the phase 2 of the project that I will explain later. So the components of care that we identified first in the evidence and then that we discussed with the focus groups were housing. So first, where people would prefer to live. So there are multiple descriptions of housing and housing types, but just a summary, we looked at the people living in their own home, so mainstream home, or living with family, or renting a home. And then community settings, which we included people, this development of flat or villages with communal spaces, or residential care. And then we included also geographical locations, so where would people prefer to live? And when thinking of moving or living in these community settings with communal spaces, the age of the co-residents or the neighbors. Also the preferences for use of assistive technology, the preferences in the decisions or on their daily routine, and the flexibility of care that they would want to have. The preferences for the provider of care, so who provides the care, either family or a regular staff or friends, etc. Also, we included the preference or the importance for them of having somebody providing care that respects and know their spiritual, cultural, religious, and sexual identity. So the value that they had on that, on the provision of care, respecting those beliefs. And finally, we looked at the community assets or resources, so importance that people gave to different community assets that I will describe more in the results of the study, but we included things as reliable public transport, having access to green spaces, to places of worship, sports ground, etc. And then the quantitative work, this came after we finished the focus groups. It was a survey of people aged 50 plus, so 50 years and older in England. And as I mentioned before, Kantar ran the survey with their online panel. We included people from the general population, but we had specific quotas. So quotas means including different groups of people to make sure that the group of people, participants that we had in our sample were representative of the English population. So we collected information from the demographic, socioeconomic characteristics, the location, and having or not experience of care or being a carer. And also with the survey, we had the questionnaire, but also we included the discrete choice experiment to explore the strength of the preferences between the different attributes. I'm not going to go into detail on the DCE because Michaela will explain it in detail. So what we did with the survey, so we had a development phase, which again was based on the findings of the phase 1 and in co-production with our group or involvement group that I mentioned earlier. Then we tested this survey with different people. And then we piloted it, the final survey, to see if it worked and if it covered what people thought of important. And then the main phase of the survey, we ran it in over 2,500 people living in England, aged 50 years and older. And then we analyzed the data, and that's what I'm going to show you now. I'm first going to start with the results of the qualitative work to kind of set up the base of what we then included in the survey and to make sense of this, of the findings of the survey. So in terms of the main findings, one important key component that we discuss with the participants is that people in general don't think of what they would need in the future. So when we started the discussion, a lot of people said, oh, actually, I've never thought of this, what I would want as my care needs increase, or as I get older and just need some type of support. But then when we kind of explain and we discuss further what would mean the future needs, an important issue was that people value their independence. So they want to keep their independence for as long as possible. And also they highly value having control over the daily routine. And we had really good insights of people that had experience with care and how important for them it is to control the meal times, the time they wake up, they go to bed, etc. So they value that control. And also it gives them the sense of independence and that they still control their lives. Also, people value having social connections, so being able to have these social connections. And a nice discussion that we had, it was the importance that of neighborhood and neighbors during and after COVID. So they got to know more their neighborhood, and that's why also they value staying in their own neighborhood or nearby, so that because they know what community resources are there, they also know their neighbors, etc. And in the community assets, what they highlighted as important were the reliable transport, as I mentioned, places of worship, having access to shops and places of culture or cultural facilities, green spaces and other leisure spaces. That we included those for the survey or the second phase. And then we discussed when people considered moving to community settings, one were what age of co-residents would you prefer to live with? They were mixed in that. But an important finding that we had is that people from lower socioeconomic groups would consider moving to a community setting so that they can access better quality of housing and care. Also importantly, the relationship with the provider of care and that importance of having a regular carer so that they can build the relationship with that person. And important of the beliefs and values, so being respected in their beliefs and values. And that's very important with such a diverse population that we have nowadays in England. And also related to the assistive technology, there was an important technological divide, and people saying that would be an important barrier for them to engage with the use of technology. And then the main findings of the survey, importantly, there is a high proportion of people responding don't know. And this is linked with the finding that I mentioned before in the qualitative work, is that people, they don't know what they prefer. So they haven't thought about it. So that's also important. They currently don't know what their preferences are. But then when asking them for certain preferences, then they had their preferences and in certain components of care. Importantly, the 47 or almost half of the participants do not have enough information to make care choices. So actually they don't know. So first, we have a problem of that people don't think of what they would prefer, but also they don't have enough information or what are their care choices. And then when asking them where would you know or would you know where to find information, more than around 60% they don't know where to find information. Importantly, the people that are using care, so are users of care, are more likely to have information about their care choices. So they are more informed than people that are not using care at the moment. In terms of the housing preferences, around 40% would choose to stay in their own home and make their appropriate adaptations. And if moving to another home, 30% would move to another house or flat more suitable for their needs. And sometimes this is referred as downsizing or right-sizing. And around 14% would move to a community setting. There were important variations in the preferences for care between different people from individual characteristics, so between age, gender, ethnicity, sexual identity, etc. In general, 73% of people stated that they would need to have substantial choice over the care and support services, and around 90% would want to have as much control over the daily routine. And again, this is also something that we found with the qualitative work. Users of care are much more likely than non-users of care to want substantial choice over their care and support. And probably this is because they already know what is out there and they have more information about their choices and about what the experience of using care. They know what it means, so they would and they value more having the choice and flexibility of care. There were important social gradients in the preferences for care. So we found a significant social gradient in information about care choices, with people with higher income are more likely to have enough information about their care choices compared to people with lower income. Also, we found that people with higher income are more likely to report needing a substantial choice and flexibility in the choice compared to people from lower or with lower income. And in terms of the moving to a community setting, so remember we asked the question of, if you move to a community setting, would you prefer your neighbors to be of mixed age or your same age group? And compared to younger people in the sample, older people that responded to the survey would prefer to live with people of mixed ages rather than the same age group in this community setting, so in the flats and or villages. And in relation to the community assets, the people value highly the having access to the community assets and the infrastructure when planning their care. And we found some differences between participants. So women compared to men attached higher importance to the community assets that we included. So reliable transport, places of worship, shops, etc., but not sports grounds. So that was the only one that women attached less importance to compared to men. Also importantly, people from Black and Asian backgrounds compared to white British people attached a lot more importance to living near places of worship, and older people compared to younger people. I already mentioned the difference between men and women, but that was very marked with this community resource of access to the places of worship. So just to wrap up, we had in this survey, and then with the information that we got from the focus group, we had a large sample of people 50 years and older, and we discussed with them, and with the survey we got a lot of information about the components of the future care, including different housing types, community assets, use of technology, provision of care, control and dignity. And as I mentioned before, there are differences and variations across the sample between these components. Our findings highlight the significance of enabling older people to maintain their independence and control over their lives, and people usually prefer care options that would allow them to stay in their own home for as long as possible. And there's also with the adequate adaptations, and if that's not possible, having their own space with in a flat or in a smaller house, just appropriate for them. And it's especially important when people reach this stage of requiring care support, and they value their flexibility and the control of their daily routine. Importantly, there was a sizable proportion of people that do not have enough information or where to find that information. And I'm going to come to that on my next slide. But also people value having access to the community assets and the infrastructure that the community provides when planning their care. And that's also something to bear in mind when planning the packages of care. There were, as I mentioned, there were important differences in the preferences for some components of care between socio-demographic groups, such as between males and females, and between participants from different ethnic and socio-economic groups that, again, need to be considered when planning the models of care and the packages of care that we offer. There was an important social gradient, and with the availability and access to information that could indicate inequalities between socio-economic group. And this is highly important, and importance to targeted outreach and support initiatives to ensure equitable access to care resources. And there's also a need to ensure that information on care services is more accessible to people from lower socioeconomic groups. Thank you.
Thank you, Magdalena. We gave you a target of 20 minutes and you've done 19, so that's pretty impressive. So thank you very much. All right. So yes, any questions, please? I've got one question that's in the Q&A, and people, in a minute, we're going to have a second presentation from Michaela, and you may have questions for her as well as for Magdalena, so we'll keep those going. But a question, Magdalena, you mentioned the technology divide. Can you say any more about this and what variables were associated with this?
Yes. So I know that Michaela will touch a little bit on the assistive technology, because we included that specific question for the DCE. But in the qualitative work, when we discuss it with participants, they said that they would that the technological divide was in terms of how to use the devices, but also they were aware that technology changes so quickly that they were concerned that once they had a device that or technology that would change immediately, and they're not going to be able to keep the pace. And also in terms of knowledge of how to use it, but when it breaks down, for example, and they have to repair it, they won't be able to do that. So that was a concern for the older people.
Okay, thank you. And a question from me. I mean, you went through very quickly the findings, so thank you for that. I should say, by the way, that as was posted in the chat, the findings from the first phase, the qualitative phase, are available now, and you can see the links to get the details there. The findings from the quantitative phase are being shared with Department of Health and Social Care at the moment, and so they're not fully sort of accessible, but we will be having reports available soon, so you'll be able to access the full details if you want. And of course, the recording is available. But just going back to what you presented on some of these variations, you said between socioeconomic groups, ethnic groups, age, gender, and so on. Were there any that surprised you, given you did all the literature reviewing and then the focus groups?
Yeah, I think what was surprising was the amount of people that don't have or don't know about their care choices, so the information, and also that they don't know where to find the information. And surprising and kind of is the inequality that exists in the access of information. So people with higher income show that they know where to find that information, and that immediately sets up a gap in between different groups of people. And also that in terms of the preferences for the community assets, it wasn't shocking because we covered this in the focus group, but the differences between ethnic groups in some of the community assets, so the highly valued access to worship, places of worship and cultural facilities.
Okay, thank you. And I've got a question from Tony Johnson. So Tony says, didn't hear any reference to supported sheltered accommodation. Was there a reason for this? So
yeah, so we in the qualitative work, we covered different types of housing, and we had few people knew about the different schemes. So because of the, well, of course, that we try to group and because of the not lack of time, but because of the design of the study, we had to group some of the characteristics of housing, so living in their own space versus living in places with communal spaces. And in the survey, we couldn't include that, one, because it wasn't prioritized by the involvement group. So we just covered living in their own home and certain characteristics, but we didn't include it in the survey as a specific housing type or scheme.
Okay, thank you very much, Magdalena. I think what we'll do, we'll go to the second presentation now, and then if you have people participating, if you have questions that you've had now a chance to think about what you've just heard, you have further questions, Magdalena, please put them into the Q&A, whatever it is, column on the screen anyway. So we're going to go from a beautiful Chilean accent to a beautiful Italian accent. So I'm going to go to my LSE colleague, Michaela Tonelli, who's going to talk about part of the survey. Michaela, over to you.
Brilliant. Thank you, Martin. I hope you can see the screen now. We changed to my presentation. Well done. Great. I'm pleased to talk to everybody about the findings, and in particular, as Magda already anticipated, with this presentation, we are covering phase 2 and the methodological side of the collection of discrete choice experiment data. In particular, with the phase 2 of the project, we wanted to explore how middle-aged and older people in England think of older people with high care needs today, would trade off different elements, characteristics of social care arrangement. And we will talk more about how we use this data to calculate willingness to pay. So we refer to what Magda nicely said until now in terms of service approach. Now we will tackle a bit more about the methodological side of things, looking into the choice modeling and the willingness to pay methodology. Choice modeling is we can say a commonly used method in health services, but they are less frequently used in a way in social care. So we were quite excited to import the methodology to social care application. The reason why we use and we chose this specific methodology is because it enables to measure strength of preferences, as Magda already anticipated, and we would measure the utility attached to different alternative scenarios or type of service provisions, and this was the key for our choice. Discrete choice experiment survey allows to collect specific data that can then analyze to produce such findings. So analyzing the DEC very much enable us to measure how preferences are influenced by different characteristics of service provision. For example, you can capture the value, responded value, more of an element in terms of who provides care versus location of care, for example, or you can also quantify how much you're willing to pay for receiving service A, a particular model, against another one. Or you can also calculate probability of uptake or preferred package of care, and this can be quite exciting for policy when they have to model service provisions. With this slide, really, I would like to kind of showcase to you an example of choice that people had to complete in order to give us the data to be analyzed and to capture their preferences. Every time, respondent had to choose between two different care models that they are described according to specific characteristics. And these are the attributes. By attributes, we mean the feature of the care model. Here we have 7 of them: housing, location, who is the provider, respect for the identity that Magda already showcased, the importance from the qualitative work, as well as access to community services, technology, and social care cost. So a lot from previous phases of the project help us to phrase this choice model. And also we have the level. So for each of these specific characteristics, we have different values of options attached to them, and I can explain more at the end if we have time. I can go through the model that we used, but each of these was described in terms of housing, for example, own home, retirement village, against more options, including shelter housing and more. So as you can see here, there is a flow of the participants. We have almost 4,000 people participating to the exercise, but not all of them completed the questionnaire. So in terms of DC questions completed, more than 2,000 completed them all, but still we had to screen these responses, and because we wanted to check for the reliability of the choices, and we concentrated the attention on a particular subgroup. We analyzed those that responded in a consistent way. We were quite pleased because of those that we analyzed, of the direction of the results, very much as we expected from the previous phases of the work, and the respondent presented similar characteristics compared to census data. So this was quite important and reassuring for us. In terms of analysis, or in terms of messaging coming, so for the choice modeling, we were able to capture the most value attributes and the relative importance, ranking them. So we can say that all the service characteristics that we pictured were very valued, apart from one: location, current neighborhood versus elsewhere. This is not, people didn't place so much of a preferences on these specific attributes, but they valued all the rest, and receiving support from carriers arranged by the local authority was the preferred element. As you can see, there is a bit of a ranking from the most preferred to the least preferred, and you can identify elements that Magda already presented to you from the qualitative work. So the carrier very much valued, as well as identity, location, technology. We still capture the technology divide here, so no use of technology device was preferred compared with use. And then cost, in terms of social care costs met by the individual person, and access to community services. So using this data, the output from the regression modeling was used to calculate also willingness to pay. And in terms of willingness to pay, because we had these cost attributes, we were able to model the maximum price a service user was willing to pay for a particular package of care, but this doesn't need to be exactly how much they should pay. It's an indication of strength of preferences. So as you can see from this example, we have that to receive support from care arranged by local authority, our respondents were willing to pay more than £100 extra. Again, we repeat the same exercise using another metrics, walking time minutes instead of cost, and we calculated the acceptable walking distance. And again, we have same direction in results. So to receive support from carers arranged by local authority, respondents are very willing to pay to travel beyond walking distance. As you can see, again, very much valued attributes. Something else that we did with the output from the regression modeling was to use this information to calculate probability of selecting alternative models. Every time we compare two separate options, option A and B, our option A is fixed, is the preferred one, the one that participant most likely valued, and you can see it's pictured on the screen with all the different characteristics. Every time in option B, we adjusted, we changed just one of the attributes level. So we just, for example, variation for housing setting from own home to other options. You can see there is a shift. So there is, again, still the majority of the individuals are willing to uptake, to prefer the option scenario A, but still there is some preferences for scenario B. And this is an opportunity to compare different models and options, viable options. Just to wrap up, I know that we want to allow time for questions. I've got a few comments from the DC findings. So all care attributes, as we said, are important when making decisions apart from locations, and the main factor that influencing people's choices is the providers who provide support with the care tasks. We found also differences between age groups in strength of preferences, so there were a number of subgroup analyses that we conducted, and we captured that older people have a stronger preferences than younger people for continuing to live in their own home with appropriate adaptations if required, and again there are strong preferences for not using assistive technology. There were also some challenging. Overall, the experiment was very much successful. We were able to apply successfully DCs to social care environment. But in terms of challenges, they are very much applicable to panel surveys overall selection bias. So it was very much important for us to triangulate the results from what we capture from the DC and compare with previous findings from the qualitative work that Magda conducted and previous research, and very much supportive the direction of results and everything. In terms of trade-off, the fact that we had the sensitivity in a way, we looked into trade-off looking cost attributes, but also we use other metrics. We ended up having similar results, very much reassuring, and it helped us to fill in some gaps in a way because the cost attributes was very much relying on expert opinion, and we were quite reassured by the fact that also using other metrics, still we were able to capture similar strength in preferences. Martin, if it is okay, I'll stop here and I'll leave to you and colleagues for questions if there are any, and I'll try to answer as much as I can.
Thank you, Michaela. That's brilliant. Thank you very much indeed. Right, so we've got time. So if we've got some questions, which I'll just come to in a moment. And if you have anybody has questions for either Magdalena or Michaela, please bung them into the Q&A or the chat. We're monitoring both of those, and we'll make sure to ask them. If we run out of time, we'll try and answer you afterwards. So there were three questions I wanted to pick up, and they're kind of probably for a bit of Magdalena and a bit from Michaela, but I don't know how you can work them. And I think what they all also pick up on is, to some extent, some of the things that you can explore in depth through focus groups and in discussions and so on, and you can't explore in the same depth in a quantitative survey, given what's there. What the quantitative survey allows you to do, in the way that Michaela showed us, was those trade-offs to see how people really do weigh what are their preferences across these different attributes of the care setting. So let me just go. So one of the questions is from Erica. Erica sent two questions in. Thank you very much. So the first one, I'll just read this. Which geographical areas were covered by the survey, and where was there information about care choice, and where was information about care choices easy and difficult to find? So do we know which localities where the information was easy or difficult to find? Also, did respondents seek hard copy or online information? Now, I think we haven't got answers to all of those questions, but Michaela, Magdalena, do you want to, one of you want to answer, or both of you?
Yeah, I think, I mean, Magdalena can definitely follow the questionnaires, the answers. They very much rely on respondent across overall England, and we try our best to cover the nation as a whole, and I think we were quite successful in terms of covering different areas across England. The questionnaires, in terms of the disease and the other elements of the questionnaires, we collected data using online panels. So online versions of the questionnaires were made available, and people could complete the online and refer back to our Kantar partner that collected data on our behalf. They submitted the questionnaires to the panel of respondents and collected data on our behalf, and we were kind of happy to deal with the analysis. Magda, I don't know if you have anything to add.
No, I think you covered everything. So we make sure to cover every region of England. So we covered northeast, northwest, and so on.
Yeah, but and just to say, we haven't analysed. I mean, we don't. What you get with these survey companies, they've got this group you can access. You have some information about them, but for confidentiality reasons, you can't get to access it to finer level of geographical location. So that's one of the challenges, if you like. So let me come into a second question. This is from Emma Kearney. Was there a preference among participants for accessing social care information or applications through traditional analog systems because of the digital divide? If only technical means were available, did they feel there was sufficient support to assist them where they were not technologically savvy? Magda, maybe I'm not sure we can answer.
Yeah, I'm going to answer this because we covered this in with the focus groups. And when we discussed with participants, there were mixed views. So they know the value of having access to technological devices and services such as telecare, etc. But they also like the face-to-face contact and the human contact, and they said and they stressed that the importance of having that human contact, especially for care services and accessing that. In terms of where to access the information, we didn't cover that, unfortunately, but we did talk about the how did they feel of if they had sufficient support, and they don't. They think that that's why it was difficult for them to think of engaging with assistive technology, because they thought that they were not going to have the support in place to like if something goes wrong, what to do. And there were usually people that were more keen in using that had previous experience with a computer, either because of their work and that they involved some technological things such as computers, etc., compared to other people.
Okay, thank you very much. I'm just going to carry on, Magdalena, for a moment, then maybe Michaela afterwards. There's a question from Grace Lewis, which I think you sort of answered some of this at the start of the question, which is, why do you think people prefer not using assistive tech? So I think to some extent you've answered that, but you may have more to say, and Michaela may. And then Grace says, I noticed about 95% of respondents had no experience of receiving social care. How do you think this will have influenced people's preferences? Michaela first, and then I go to Magda first. You go first.
I think I'll go first. The first one, sorry, can you repeat the first one, because it was a really good discussion about that one.
Why do you think people prefer not using assistive tech?
Yeah, so apart from the technological divide, I think also people highlighted that in terms of care, they would very much prefer to have this human contact, because they said when you have the care through a screen, the carer or the people that is providing the care, they usually don't perceive everything that is happening. So they thought that, for example, when you go to an appointment or the care, as soon as you go in, the carer usually knows what is happening, and you don't because with behind the screen usually it's not everything, you can't see the whole picture. So that's one of the discussions that we had. Yeah, and then the second question.
No, you put me in a difficult position because I've been looking at other questions. Hang on.
Yeah, I think it was in relation to the experience of care, how this experience might have an impact on their preferences. And I think this is an element that we try to address in our group analysis. We couldn't picture a strong difference in preferences, but this is something that we address, and I'm very happy to share the details about these groups with the audience. And later, I think we are preparing publications, and we will dig into these sort of elements in the discussion. But I don't remember we picture strong differences in preferences between groups. Yeah.
Yeah, I think. Sorry, can I add something? That one of the limitations that we had is there were some differences, but as Michaela said, they weren't massive. Although because it was the survey is just one point in time, we don't know if that changes the differences between, for example, younger and older people is due to a generational difference, or whether there is a different, like a cohort effect, so where people move to the needing the care if their preferences would change. Unfortunately, because of the design of the study, we couldn't cover that change over time.
Okay, thank you very much. So I've got another question from Erica, which I think follows on a little bit, and Ms. Michaela, I think one for you, but Magda, please come in if you want. So the question is, did the respondents offering to pay £100 more for local authority provision come from high or low income strata? And she suggests perhaps some people would get financial support.
Exactly. So this sort of modeling that I presented comes from the pool of the respondents. So we consider all the respondents, and in terms of breakdown, I guess we very much rely on what the census present in terms of stratifications for the nation. We then try to dig again into some sort of group modeling, and there were some differences, of course, in willingness to pay, depending on the income stratus. So definitely this is something that again can be discussed in the future when we have finalized this group analysis. But yeah, this is something that is quite interesting really to have.
Okay, thank you. I'm just going to come to a question from Jackie in a moment, but just, you know, when you're watching YouTube and these annoying adverts come in when you're trying to watch something, well, there's two annoying adverts, but they're not annoying, have been put into the chat by Jane, so they're not annoying at all. So what Jane has put there, if you haven't noticed, is firstly, there's a webinar coming up next month, which is looking at digitalisation of health and social care services. So that's next month's webinar. You can see the link there. And then secondly, some work that I was involved in, which we did previously. We published or finished it a couple of years ago now, which is looking at the potential for digital technologies to support people living with dementia or their carers, and that report is available on the Older People and Frailty PRU website. So please do take a look if you're interested in following up there, because I think the questions that you're raising, the points that are being made in the chat, are really helpful in that wider context of digital technologies and so on. So let's go to a question from Jackie Nettleton. And I don't know we can easily answer this, but so did you consider long-term condition metrics, different long-term conditions, e.g. heart or stroke failure or related conditions that affect mobility? I don't think we've got that level of detail, have we, in the study of Magda or Michaela? Tell me on that.
No, unfortunately, no.
So I'm sorry, Jackie, we're unable to give you an answer to that. We haven't got the information. I mean, what I would say is just something that's coming up in the suggestions with the comments that you're making, the questions you're putting in. We finished analysing the qualitative data already and the quantitative already, but these are rich sources of information. And I think if any of you have any thoughts for other things that could be looked at with the data we've already got, we'd be delighted to hear that. And also the nature of these policy research units that we have, the work that we do. Some of it is suggested by the research team, some of it is suggested by the Department of Health and Social Care, some of it is suggested from outside and we discuss it. So if you do have any ideas for perhaps follow-on work, and I think some of the things that are being raised here might be those sorts of things, we'd be delighted to hear those as well. So doesn't mean we can do everything, but we're very keen to hear those points. Okay, so just check, are there any more questions or comments that people want to make? I'm just checking the chat, which has got a wealth of information on things if you want to look at it, and the Q&A. Okay, so I think what we'll do, Magdalena and Michaela have done very hard work at lunchtime, so I think we should give them a little bit of a break. Let me then say just a couple of things. Firstly, to say thank you very much for joining us today, and please do look out. The recording will be available on the website soon, and we would love to continue to get your comments or thoughts on the work we've done and what we might do in the future. So thank you for that. And then what I mentioned earlier, so the next webinar is on Wednesday, the 15th of May, same time, 12 to 1, same place as a webinar. And the title of that is the digitalisation of health and social care services for older adults, learning from COVID-19. So if you want to, you can go to the chat and you'll see the details of registration. You can go to the website for the PRU and get them there as well. And you're probably on a mailing list for us somewhere, so you'll get to hear about this one way or another. So please do join there. So I'm going to thank everybody. Michaela, Magdalena, thank you very much for excellent presentations. Jane, Linda and Ursula, thank you very much for excellent organisation, and everybody remaining on the webinar, thank you very much for excellent participation. And we'll see you again next month. Thank you.
Thank you. Bye. Bye-bye.